Okay, so just a little bit of reminder on kidneys. Kidneys do a lot of fluid and electrolyte controlling. Um, there is a lot of kidneys are going to control the sodium, phosphorus, your acid, metabolic acidosis or alkalosis, your phosphorus. Um, Things like that. So that's a factor of your electrolytes, your kidneys being part of that. Another thing is your hypothalamus. If you remember that, has to do with your thirst, water reabsorption. All these things are going to be a factor for your electrolytes as well. Here's just another example of your adrenal cortex. If you might remember, it makes aldosterone. It's going to decrease if you lose any sodium and water, it's going to hold on to that. So this is just a review. You don't have to memorize this. Thirst is a big factor. That's something that works really well. Um, if you're thirsty, basically that's coming from your hypothalamus. So if you've got mucous membranes that are drying because you're low in fluid, this causes the person to say, I'm thirsty, want to drink fluids. So hypothalamus is taking care of that. As you age, some patients lose that mechanism. It's not as strong in a 18-year-old as an 88-year-old, and so that's why you see so many elderly patients becoming dehydrated because they just don't have that mechanism to say, hey, I'm thirsty, I need to do this. So intracellular electrolyte and extracellular electrolyte. So how many of you know what the extracellular fluid primary electrolyte is? If you said sodium, you are correct. Intracellular is sodium. Extracellular, wow, let's back that up. Intracellular is potassium. Extracellular is sodium. Let's back it up again. Make sure you got that. Intra is potassium, extra sodium. Inside the cells, potassium. Outside the cells is sodium. Sodium and potassium, those are the two. So you also might hear something having to do with spacing, first, second, third spacing. Patients that lose fluid out of their intravascular and they retain fluid in their cells, they become very edematous. So we're talking second and third spacing. That's a big factor for some of these patients. You probably have seen them in the hospital already. Just another graph that you want to get an idea of what's going on with your solids, extracellular fluids, those things right there is 60%. So 60% of your whole body is fluid, solids only 40%. Kind of interesting. So let's talk about sodium for a little bit. So sodium is, I just mentioned, your extracellular fluid. That's the number one extracellular fluid. So, main functions of that is just to help with extracellular osmolality, regulates water balance. The big thing about sodium, notice it's in red, is neuromuscular. Neuromuscular response helps with the nerve impulses, fibers, also helps maintain your acid base and your water distribution. Big factor for sodium. We all have to have that. Notice it's 135 to 145. That I would remember. 135 to 145 is normal for somebody on their serum sodium level. So what happens when you are hyponatremic? Hyponatremia means what? It means you are low in sodium. So if you are low in sodium, it could either be dilutional hyponatremia or water intoxication. Every year, someplace in the country, we have a fraternity house, and they're going to they're going to drink all the water they can. You got some contest going on, so let's see how many gallons of water we can drink. Well, what ends up happening is a patient becomes water intoxicated and they drink too much water and they end up dying because they became hyponatremic because they drank 8 gallons of water in 2 hours. So this is hyponatremia. So because of this, hyponatremia, you're going to have swelling and edema. The big thing that happens, behavior changes, is big changes are confusion, lethargy, convulsions, coma. These patients end up going into a coma and convulsions. So it's a neuro thing, Neuro, a neuro thing. They get muscle weakness. These patients basically go into a coma, may go into seizures, and they end up dying if you're too low. So the question always comes up, how low is too low for these patients? Well, it all depends. I've had patients that have been in hyponatremia and they're at 116, and 116 for that patient, they don't have any symptoms, and somebody else at 116 may have a lot of symptoms. So everybody's going to be different. So signs and symptoms then, it varies. You're going to have the neuro changes, seizures, and so you have to watch for safety measures. If somebody is really low, you're going to watch for seizures. So they may have the seizure pads on the bed. So how are we going to treat hyponatremia? Well, usually if it's done by they have too much fluid on board, so usually if it's dilutional, we need to put them on fluid restrictions. That's one way, and that can bring it up another way. The other way is we can administer a hypertonic solution. So an example of what they use is 3% saline IV solution. You have to be very cautious when you give 3% sodium solution to a patient IV. It's got to be given very slow. Too high, and the patient will all of a sudden go to hypernatremia. So other things you have to do is you use normal saline instead of distilled water for irrigations in their IV. If they're drinking anything, drink with fruit juice rather than water. That's one way to do that. So we can give them IV with sodium. They can drink fruit juices, normal saline instead of distilled water, or just regular tap water as well. Hypernatremia then. Hypernatremia, you got too much sodium on board, and usually the body's going to use that thirst mechanism. So the hypothalamus and say, hey, you're thirsty, you need to drink more water. You've got too much sodium. If you drink a normal amount of water, then of course that's going to make your sodium go down in your blood. The same as hyponatremia. Hypernatremia has neuro issues. So the same thing, you're going to have confusion, lethargy, you have seizures, go into a coma, going to have the extreme thirst. Because these patients are low in water, they have high sodium, they're going to have the dry, sticky mucous membranes. That's the big thing about these patients that you see. So how are we going to treat this? Well, we can administer water to them, regular water, so that's a good idea, especially if these patients are on tube feed, regular water between hypertonic tube feedings. Drink regular fluids regularly if they're elderly. They can also be given diuretics, so if you give someone a diuretic, they will pee out extra sodium. That's one way to decrease it. So you have to just monitor fluid in, fluid out, thing of that nature.